Hello and welcome to the live interactive webinar on cow's milk allergy and functional gastrointestinal complaints in infants. My name is Anna Nowak-Węgrzyn. I'm a professor of pediatrics at the New York University School of Medicine in New York City. It is my great pleasure to serve as the moderator for today's session that is really fantastic and will be highly educational and interactive, and you will leave it with many, many clinical pearls that will help you manage your patients better. This is the last in the series of practical pediatric webinars, which started on June 18th, and all of these webinars have been recorded and can be they are accessible to you on Nutricia website. So you can go back if you didn't have a chance to participate in some of those webinars, but all of the topics are extremely timely and clinically relevant. So I would encourage you to take advantage of that resource. We have two amazing speakers who are the leaders in the field and are truly an amazing resource. Professor Mario Vieira, who is the head of the department and coordinator of the residence program in pediatric gastroenterology at the Hospital Pequeno Principe in Curitiba, Brazil, and Professor Rosanne Meyer, who is a pediatric dietitian honorary senior lecturer at the Imperial College in London, United Kingdom, and also a visiting professor at KU Leuven in Belgium. So they are here to share their experience, their clinical acumen with you in dealing with the most challenging presentations of cow's milk allergy and functional gastrointestinal disorders in infants.
Thank you, Anna, for that very kind introduction for both of us. Between me and Dr. Mario Vieira, we're going to try to address this very complex topic of cow's milk allergy and functional gastrointestinal disorder in infants. We are going to actually do it in tandem. So I wanted just to talk about our conflicts of interest. Mine are in particular related to academic lectures and also some academic grants, and that is similar for my colleague, Dr. Mario Vieira. If we move on over to look over to the overview of this webinar, what we'll try to do is start off with Dr. Vieira with the clinical presentation and the clinical management of functional gastrointestinal disorder. Then we're moving on to the clinical presentation and clinical management of non-IgE mediated cow's milk allergy. And then, of course, this very tricky topic of cow's milk allergy and functional gastrointestinal disorder. I'm then going to take over and I'm going to talk about the involvement of the microbiome in both disorders, just very short. Then clearly the management from a dietary perspective in terms of cow's milk allergy, and the same with functional gastrointestinal disorder. And then finally, we're going to do two very nice and interactive cases. I'm going to hand over now to my colleague, Dr. Mario Vieira.
Thank you very much, Rosanne, for your kind introduction. I want to thank everyone for joining us today and Danone Nutrition for this kind invitation. It's a great pleasure for me and an honor to join this large audience online from different parts of the world. And I'm also delighted to be joined by Anna Nowak-Węgrzyn and Rosanne Meyer, two amazing and extremely well-known specialists in pediatric allergy and nutrition with such a vast experience in food allergy. Well, I know I will focus today on a very difficult topic we deal with in our daily practice, and I'm sure most of you see many patients with these manifestations many times every week. So I should start off by asking the question, what are functional gastrointestinal disorders? We define them based on international criteria we refer to as the Rome criteria, which started from a group of experts in Rome in the 1990s. So functional gastrointestinal disorders are defined as disorders of the digestive system when symptoms cannot be explained by the presence of structural or tissue abnormality, which means that we have to try to diagnose these conditions based on the good old clinical history and physical examination. It doesn't mean you do not have abnormalities, but in clinical practice, you're not able to detect them. If we actually look at research, there's a lot more on the pathophysiology of these disorders. The Rome criteria started in the late 1980s in adults, infants and children were ignored at that time. In the 1990s, pediatricians started to discuss this topic, but still there were few studies in infants and children, so recommendations were based on adult data. In 2006, the RUM criteria were developed specifically for pediatric age groups, with the more recent version of the RUM 4 being published in 2016. So in the next few minutes, I will address those functional gastrointestinal disorders occurring in neonates and toddlers that you can see listed here. Most of them you will recognize, especially the most common highlighted in yellow. That will be the focus of my talk today. But how common are functional gastrointestinal disorders? How often do we see babies with these manifestations? This is the prevalence data from a study published some years ago. The literature search identified studies with a variety of designs, populations, and definitions of symptoms, reporting a prevalence of regurgitation from 3 to 87%, of colic from 2 to 73%, and of functional constipation from less than 1 to 39%. These authors also sent questionnaires to healthcare professionals from different parts of the world, and the responses revealed that the likely prevalence for colic was 21%, for regurgitation 29%, and for functional constipation 18%. There are recent studies from Latin American and African countries reporting also high prevalences of functional gastrointestinal disorders in infants. And particularly this study in Africa showed that 2 or more symptoms occur together in more than half of infants. So whenever we discuss functional gastrointestinal disorders, we discuss them one by one. But of course, in clinical practice, most infants present with a combination of them. Well, functional gastrointestinal disorders are sometimes called minor gastrointestinal problems. These so-called minor problems become a source of stress and anxiety to parents because babies cry and fuss. So these conditions in infancy are extremely common. So it's really important to appreciate what is normal. Crying and fussing are normal for babies. And that's, of course, exactly what we see. Babies cry. So this study from the 1960s found that normal babies cry for almost 3 hours a day. The crying reaches a peak at 6 weeks of age and then gradually decreases as babies get older. This more recent study reviewing articles involving more than 8,000 infants from 7 countries found that the mean cry duration was stable at around 2 to 3 hours in the first 6 weeks and dropped to 1 hour by 10 to 12 weeks of age. This graph is almost mirroring what's happening in colic. Colic is much more frequent in the first 6 weeks and decreases gradually up until 10 to 12 weeks of age. One important aspect we have to be aware of is that functional gastrointestinal disorders, together with crying and fussing, cause distress to the whole family and may lead to consequences, including early cessation of breastfeeding, frequent changes in milk formula, repetitive medical consultations, use of medications without proven efficacy, and potential adverse reactions, as well as to unnecessary investigations. All these consequences have also a significant impact on personal and public health care costs. In less than 5% of these crying distressed infants, an organic disease may be present. Of course, it's important to rule out organic causes with a proper clinical history and physical examination, excluding these alarm signs listed here, using obviously a careful clinical judgment. This is extremely important. But parents want to know, why is their baby crying and fussing so much? Is it colic? Is it constipation? Is it reflux? Or cause milk allergy? So I will spend the next few minutes talking a little bit on the definitions and practical management of these conditions. Infantile colic used to be defined many years ago by the rule of threes: crying or fussing for more than 3 hours per day, for more than 3 days per week, and for longer than 3 weeks. In terms of the ROM 4 criteria for clinical purposes, colic is defined as crying or fussing without an obvious cause, with no alarm signs in a healthy infant who is less than 5 months of age. What's the best treatment? In the vast majority of cases, treatment does not consist of curing the colic. This is extremely important, but of helping and supporting parents coping and getting through this period in development of their baby. In my practice, I always listen, and discuss with parents what are normal crying patterns in babies. There is evidence from different randomized controlled trials that a particular probiotic, Lactobacillus reuteri, can reduce infant crying in infants with colic. This network meta-analysis found that this specific probiotic and some dietetic approaches, as the use of partially hydrolyzed formulas, are better when compared with all other interventions for the treatment of infantile colic, especially in patients who are exclusively breastfed. This refers to the probiotic. Let us move to constipation, which is much less frequent than colic and regurgitation and is extremely rare in breastfed infants. This is the definition of infantile constipation, functional constipation, according to the Rome criteria that must include at least 2 of the items listed here. So functional constipation is a clinical diagnosis that can be made based on a typical history and normal physical examination. It is important to differentiate from infant dyschezia. These are the infants who strain for 10 to 20 minutes, scream, cry, and turn red in the face with each effort to defecate. Stools are soft and pass several times daily. In most infants, symptoms resolve before 9 months of age without any intervention. How do we manage these patients? In breastfed infants, as I said before, functional constipation is extremely rare. In the absence of warning signs, parental reassurance and guidance is essential. For formula-fed infants, nutritional interventions may be beneficial. There is some evidence supporting the use of partially hydrolyzed formulas with prebiotics, as well as palm oil-free formulas to improve stool consistency. If symptoms persist, osmotic laxatives as lactulose or polyethylene glycol may be recommended. What about reflux? These are the Rome criteria for infantile regurgitation. You have 2 or more episodes of regurgitation per day for 3 or more weeks in an infant with no signs of organic disease. We know that almost all babies in the first months of life regurgitate. It's essential to differentiate gastroesophageal reflux from gastroesophageal reflux disease, which is defined when troublesome symptoms or complications occur. Of course, this is a definition open for debate. Is it troublesome for the infant, for the mother, or for the pediatrician? Now, if we look at the natural history, there has been a number of studies on infant regurgitation. It's extremely common in the first months of life. As we can see, as time goes on, it begins to reduce naturally without any intervention and remarkably reduces by the age of 12 months. Our job in these infants is try to identify patients with organic disease, looking for alarm signs that will determine the need for appropriate investigations and referrals. If there are no alarm signs, conservative management is recommended. We may have those babies that we need to review feeding techniques and volumes, and of course, regurgitation is not a reason to stop breastfeeding, which must be supported whenever possible. I'm going to finish with a challenging topic that is the role of non-IgE mediated cow's milk allergy in gastrointestinal manifestations. Here is the difficult association between GERD and cow's milk allergy. You can see that these symptoms in the center of the slide here may be observed in both conditions. And now, these ones are also manifestations observed in functional gastrointestinal disorders. This overlap of clinical manifestations makes it very difficult for us as healthcare professionals to make a precise differential diagnosis. It's important to have in mind that you need more than one symptom to recognize cow's milk allergy. Not one symptom, but an association of symptoms. And of course, diagnosis should be confirmed by an elimination diet followed by cow's milk challenge. When it comes to the infant with suspicion of GERD, when conservative management is not effective, a cow's milk elimination diet has been recommended in all guidelines for GERD and food allergy, as is the case of these joint guidelines from ESPGHAN and NASPGHAN. The rationale for these recommendations has been endorsed by this interesting recent study showing that when compared with controls in infants with non-IgE mediated cow's milk allergy, the elimination of cow's milk protein from the diet improved symptoms of GERD, esophageal peristaltic function, and increased mucosal baseline impedance with improved mucosal integrity. What do other guidelines say? There are plenty of guidelines published in different parts of the world, and this is a more recent milk allergy in primary care guideline that, as well as other international and national guidelines, recommends that for infants with gastrointestinal manifestations that we discussed before, especially those who are formula fed with persisting symptoms despite the measures, conservative first-line measures, an exclusion diet must be considered when a history and physical examination suggest cow's milk allergy. As in all guidelines, measures to support continued breastfeeding are reinforced. And finally, it is important to note that cow's milk allergy might lead to functional gastrointestinal disorders later in life. This is a case control study including 52 children between 4 and 18 years of age who were diagnosed with cow's milk allergy within the first year of life, and 53 healthy controls. The authors found that 44% of the patients who had cow's milk allergy reported gastrointestinal symptoms, including abdominal pain, abnormal stool habits, in comparison to 20% of the controls. Also, in the cow's milk allergy group, 19% report fulfilled the ROM3 criteria for functional gastrointestinal disorders, whereas none in the control group did. So we see that cow's milk allergy may predispose to functional gastrointestinal disorders later in life, and this is another very good reason for early diagnosis and adequate treatment. So now I'm going to hand over to Roseanne, and I will return to you for the case studies. Thank you all for your attention.
Thank you very much, Mario, for that fantastic introduction to an extremely complex topic. I'm sure you can agree he summarized it extremely well. So I'm going to talk about the dietary management of cow's milk allergy and functional gastrointestinal disorder. I'm going to immediately fall into the gut microbiota, the immune response and allergy. And first of all, just want to say this is by all means not an end-all presentation on this topic, because you will have had already 2 topics covering the areas of the microbiota in regards to allergy and cow's milk allergy. So it comes as no surprise that in allergic infants, several studies show the presence of an altered gut microbiota, or how can we say a dysbiosis. We do know that bifidobacteria are the first colonizers of a healthy gut. And we also do know that in particular, the microbiota diversity is affected in cow's milk allergic children. So children with IgE-mediated cow's milk allergy typically have low bifidobacteria, and we have now got some data from Roberto Canani coming through looking at non-IgE-mediated allergies, who also have a dysbiosis but driven by Bacteroides and Alistypes kind of type. This points towards, the role of probiotics with bifidobacteria to correct the dysbiosis. Now, again, I'm moving towards more overview articles because you get, of course, much more specific publications, but there's a fantastic publication by Tom Mars where he went through 8 cross-sectional studies specifically looking at assessing the gut microbiota in children with established food allergy. It's mostly IgE-mediated allergy, but like I said, the data is coming through. So if you've got time to read, that's a fantastic overview article. There was this wonderful publication that has come through recently, and why I like it. So if you look at the graph, you have your control group, no cow's milk allergy. You've got your cases with cow's milk allergy, and what they did, they followed them up after the diagnosis. So on the day of diagnosis, took stool samples, and then after 6 months, they were all on an extensively hydrolyzed formula, but without pure probiotic. And you can see both for the aerobic and the anaerobic, actually there was no shift in regards to the microbiome related to the children with cow's milk allergy. Again, reinforcing also a significant difference if you compare it to a baseline population that actually has got no cow's milk allergy, and also opens the door towards questioning the management in future, so the active management where pre-probiotics and symbiotics play a role. There was also a very nice recent publication by Kurosh looking at stool samples of children with IgE-mediated allergy and their healthy controls. And the food allergic children had a very different microbiota when they looked at their siblings in particular. And so I think it's very well established and opens the door for future treatments when we're looking at cow's milk allergy in particular. There's actually also a lot of data looking at the role of gut microbiota and functional gastrointestinal disorder. We know of the gut-brain axis, but there is a microbiome gut-brain axis as well. We know that there is a role that the microbiome plays in different areas. Motility. So the microbiota can stimulate the transit and is shaped by transit, and it also regulates the biotransformation of the bile acids and the production of short-chain fatty acid. It has a role in regards to visceral hypersensitivity or visceral hyperalgesia, whatever you may call it. In regards to the permeability, so the mucus degrading by the bacteria, the immune activation, which were discussed actually by previous webinars also within the series. So do take time if you've not looked at those webinars. So in regards to functional gastrointestinal disorder, there's certainly this bidirectional relationship where one feeds of the other. Most of the data yet you find in functional gastrointestinal disorder in infancy related to the microbiome is mostly related to colic. And what we do know is from the studies that have been published, differences in the microbiota between infants developing colic and without colic are already visible within the first week of life. I refer here to the data that Mario presented, that in particular is within the first 6 weeks that the crying time seems to be much longer. And colic was specifically associated with the enrichment of proteobacteria, including Escherichia, Klebsiella, and Pseudomonas. And here, interestingly, the villi firmicutes and Actinobacter were more prevalent in infants that did not develop colic. So there's also an association, and you may have seen, and I touch on that as well, there was a specific probiotic that has been positively associated with colic as well. Now, you heard from Mario saying, I listen, I take a history, I listen, and I'm not doing as a dietitian anything else. And I think the dietary management, and that's the same for the medical management, starts by acknowledging the distress, whether that is cow's milk allergy or functional gastrointestinal disorder, and listening, because often you're the first person that really listens. And as you can see, there's an overlap between cow's milk allergy, functional gastrointestinal disorder. And that overlap often is very difficult to distinguish. And that's one of the reasons why it's so important for us to work together as a multidisciplinary team. That might be from a medical perspective, we start the treatment. I see the patient from a dietetic perspective. I feed back as a dietitian back to the doctor feeds back to me. So that's why multidisciplinary team is really also really important. So if we're thinking of, first of all, the principles of cow's milk allergy. I'm starting with cow's milk allergy before we go to functional gastrointestinal disorder. The principle for, in particular, non-IgE, where you see the overlap, is an elimination diet of 2 to 4 weeks, followed by the reintroduction. The reintroduction is critical so that you actually confirm your diagnosis. I want to just put here an extra little tip. I have often found we lean towards 4 weeks rather than the 2 weeks, and it's a practical reason. It often takes about a week for the parents to get to know which products to avoid, what can I have separately, and it often can happen that within the first week they make still mistakes. So we normally would go more to the 4-week side rather than the 2-week side. The second aspect is wherever you are in the world, you need to know the labeling law, and that needs to be educated. That's really important. How to avoid. You need to also talk about hidden sources, but it's not only about what to avoid, it's the alternatives. So you need to give them practical guidelines of what they can have, schools, nurseries and parties, and recipes. And then, of course, as a big overview, think about your supplementation, vitamin A, D, calcium, which are most probably your big ones. Depending on if it's the gut is affected, zinc and iron can also be big ones. And then you want to make sure that your oral motor skills are well looked after, because of course children in particular with non-IgE mediated, and that may be GERD on top of that as part of it, but those are at higher risk of developing feeding difficulties. Breast milk, of course, is your gold standard form of nutrition for cow's milk allergy, and also when we come to functional gastrointestinal disorder. Breast milk also acts as your best source of pre and probiotics, and I'm sure many of you read of the enteromammary pathway, because there's a transfer of the gut bacteria from the gastrointestinal tract from the mom through the breast milk, and then of course the sucking itself around the nipple area also transfers some bacteria. We all need to aim to follow the WHO guidelines, ideally for exclusive breastfeeding for the first 6 months of life, and we also suggest ideally alongside complementary foods to breastfeed until 2 years of age. Breastfeeding also supports the microbiome, as I've just demonstrated, and then we need to support the infant but also the mother. So we also need to make sure that the right foods are eliminated, and that's an important message. We have through IACI, where Mario is part of the members, we've published a guideline on non-IgE mediated allergy and elimination diets just for breastfed infants. And one of the important lessons is that the vast majority is cow's milk as a culprit. Plus minus, it might be soya, it might be egg if there's eczema involved, but not to go extensive elimination and just focus on the foods that really need to be eliminated. And then of course, what's important is the vitamins and minerals. In regards to elimination and breastfed children, all of the guidelines say exactly the same. DRUGMA guidelines, ESPRIN guidelines, IACI guidelines, IMAP guidelines, and I'm sure it's the same wherever you're dialing in from the world, is that we want to support breastfeeding first, and that is, if required, an elimination diet from the mother. When a formula is required, I divide the formulas into 3 categories. Category 1 is intact non-milk protein, and that's soya. Then we've got extensively hydrolyzed formula, and they are 3 categories. 2 primary, that's extensively hydrolyzed whey, extensively hydrolyzed casein. We do now, and particularly in Europe, mainland Europe, have also extensively hydrolyzed rice available as well. And your 3rd category is your amino acid formulas. I'm in particular going to focus really here on your amino acid formulas, because the mainstay of your treatment for the vast majority of children will be an extensively hydrolyzed formula. So if you're looking at what guidelines say, and do forgive me, I have not represented all of the guidelines. It's impossible for me to do so in one slide and in a webinar. But if you look at an overview, if we look at the categories where an amino acid formula, most of them are most common, it's going to be your anaphylaxis is across board, it's always going to be an amino acid formula. EOE is going to be always an amino acid formula. FPIES, there's a bit of discrepancy where there's an extensively hydrolyzed formula in the DRUGMA guidelines first, and then amino acid formulas. And Australian also talk about extensively hydrolyzed formula, but the rest, for the vast majority, extensively hydrolyzed and then amino acid formula. Within the text, you see some, if this occurs, then amino acid formula. So what I want to now do is go through some more specifics. We published a practical guide based on evidence review in 2017, where we looked for which patients would you be looking at an amino acid formula. So as I already said, extensively hydrolyzed would be for the vast majority. However, if a child fails on an extensively hydrolyzed formula, then amino acid formula is indicated. And as first line, as I already showed you, an EOE amino acid formula across board is indicated. Then in terms of growth filtering, in particular, if there's multi-system involvement, so the gastrointestinal tract or the skin, and if there's multiple elimination diet, for those, an amino acid formula based on research would be a good first start formula. Now, if I talk to you like that, that immediately should ring a bell, because those are your most common and most complicated patients when you're looking at more foods eliminated, more systems involved, skin, gastrointestinal tract, and they've got faltering growth, and lastly, anaphylaxis. Now, let's look a little bit at this in more detail. In regards to faltering growth, why have we focused on that in regards to a clear indication? I'm presenting 2 studies, but they're actually 3 studies where they've looked at compared extensively hydrolyzed formula to an amino acid formula and found, although weight for age is a very similar trajectory, when you actually look at height for age, so longitudinal growth, you see that in terms of amino acid formulas for both these studies, the statistical significant improvement when it looks at longitudinal growth. We hypothesize that although you might get clinical improvement in regards to the symptoms, what may happen, you may have ongoing inflammation. And as a result of the inflammation, of course, you have some of the cytokines that affect the longitudinal growth plates. And as a result of that, height growth does not occur. So by really removing all of the allergens, going onto an amino acid formula, that inflammation reduces, and therefore you have better longitudinal growth. Now, let's move on in terms of functional gastrointestinal disorder. I've really referred to you to publications by Professor Ivan van der Plas, and you will have seen in terms of functional gastrointestinal disorder, he's published a lot. A lot of it has already been covered by Mario. I'm going to try just to focus not on the alarm signs, which you've gone through, but just in regards to your nutritional management. So this is infants with regurgitation. In terms of GERD, you've had that information, but we're talking about regurgitation as a first line. So overfeeding, of course, is very important. Thickening of feeds, and again, for those dietitians out there, please check what are you using for thickeners. I do still find that a lot of time thickeners are used that are not age appropriate, where they're not licensed for babies below the age of 1. So that's really important. They are often pre-thickened formula as well. And lastly, of course, you continue breastfeeding. With the breastfeeding, it can often just be a question of getting your breastfeeding advisors to look at the technique. Overproduction, not a proper latch with sucking a lot of air, can often give you, regurgitation symptoms. And of course, when that does not improve, you get the consideration of an extensively hydrolyzed formula. And this is an important factor to take into account. You saw the alarm signs. So as soon as you've got a child that actually has regurgitation and actually has got more symptoms, you've heard that from Mario that it's not a single symptoms when you start looking at cow's milk allergy. But for example, if they're on top of that have got faltering growth and eczema, then you start moving towards a patient where you're saying actually cow's milk allergy might be more likely, and you might want to go to an amino acid if faltering growth was present. Again, most importantly, and that's really important because there is a natural trajectory in regards to functional gastrointestinal disorder, which Maria has shown you. Please challenge your children. Do not just keep them. If you've put them on an extensively hydrolyzed formula, move them over back to challenge them to confirm your diagnosis. This is the same for a colic, for your first kind of line. If you're suspecting allergy, it's of course cow's milk free or an extensively hydrolyzed formula, challenge important. But I think an important part in terms of colic, which I kind of hinted to before, was here looking at the overfeeding, but also here considering whether your Lactobacillus reuteri may be a useful probiotic to use. A partial hydrolysis, which you've already heard of, lower lactose prebiotics, so that kind of combination, and seeing whether that may help in regards to the management. Of course, think about the psychological support for the parents as well. In regards to the constipation, again, I'm just focusing on the nutritional part, so not the medical part, but nutritional part is outside of continuing breastfeeding, if that's available. It's really important to verify the proper formula preparation. It's often, if it's white, it's right. So if I just scoop it off and it looks slightly more powder, then that must be okay. So these finer details are really important when you're thinking about it. And actually, are they having sufficient volume per se? And as before, here your consideration in regards to allergy comes in, whether your extensively hydrolyzed, which is an EHF, might be your first one. Your prebiotics, probiotics may play a role, magnesium, and that really is where you're listening and hearing what the parents may say is also important as well. And then finally, also if they're on complementary feeding, it's fluid and fiber. However, this is an important consideration. If you're thinking about a 6 or 7 month old baby and you're just piling in the fiber but not sufficient fluid, excessive fiber also has as a side effect that it has high phytate, so it can bind many of your micronutrients. So it's, again, I know I'm a dietitian, so I'm going to say that, but get your dietitians to involved to find that balance where you're saying it's fruit, it's vegetables first, rather than adding all these supplements of extra fiber, which may impact your bioavailability of many of your micronutrients. Then I did want to touch on this. I know I get so many questions on that. The FODMAP diet for functional gastrointestinal disorder in infants. There's very limited data in children. So actually just 2 randomized controlled trials. And the pathophysiology, for those of you who've not heard about it, FODMAP means fermentable oligomonosaccharides and polyols. And the science behind it is that when in some of the adults in particular, where the data lies, they ferment within the small intestine, large intestine, they change the osmotic load. As a result of that, increase your diarrhea, and as a result of the fermentation and the visceral hyperalgesia, which causes pain outside of the bloating, and they get flatulence and discomfort. Now, for infants, there's no data. There's one hypothesis data also coming from Monash to say maybe you need to see whether babies consume excessive amount of fruit juice. That can occur. I've seen in baby foods also a lot of fruit added or fruit juice added to change the taste. So that can, because of course that can cause excessive fermentation. Sweet vegetables such as pumpkin, sweet potato, all of those, they are, and wheat-based pasta, they can in theory cause a lot of fermentation. So what I would suggest is rule everything out. And if you feel that the parents come to you with a very good history, then what I often do, I take targeted FODMAP foods out, but extremely important, once you eliminate, reintroduce them, because you certainly do not want to eliminate without reintroduction. So now what we're going to do, we're going to move on to the cases, which are nice and interactive, and I'm inviting you to take part in that.
Fantastic. This was really wonderful. I enjoyed your presentation so much. If the audience has any questions, please feel free to submit them through the question and answer window. And we'll now go to your case presentations, which are also incredibly entertaining and very educational. So I give it back to you, Maria and Roseanne.
Thank you very much.
Thank you very much, Anna. Thank you. Well, we will now move into two practical cases, and I guess all of you will identify with these patients. The first case is a 3-month-old baby boy who was referred with a history of frequent vomiting after most feeds, refusal of the bottle, disturbed sleep, and irritability since 2 months of age. He has been given antispasmodics frequently with no improvement. There was a family history of atopy. He was born after a full-term vaginal delivery with 3.4 kilos and 49 centimeters and had no immediate postnatal issues. He was exclusively breastfed until 2 months of age when cow's milk-based formula was initiated 2 to 3 times per day. After a couple of days of introducing the formula, more frequent vomiting and increasing irritability were noticed. Weight and length started to drop off the centile chart. I have some questions for you. The first question that I pose is, which investigations would you perform? Specific IgE for milk proteins, barium contrast study, endoscopy, ultrasonography for reflux, or none of the above? I think you can vote on this and then we will come back to our case. I guess most of us often see patients with these manifestations in our daily practice. Of course, we want to make sure there isn't something else going on. Mom complains that her baby seems uncomfortable and is always irritable. Many times there is a lot of parental anxiety and sometimes pressure on us to have a concrete diagnosis. Do we have our responses? Yes, okay, thank you. We can see that most of you would choose not to proceed with any investigation, but some would proceed with specific IgE for milk proteins. I will comment on this initial approach along the progress of the case. Well, the baby was submitted to a barium contrast study that indicated gastroesophageal reflux, but no anatomical abnormality. At this point, omeprazole was initiated. However, 2 weeks after this treatment, no improvement was observed. It is important to say that unless we want to detect anatomic abnormalities, barium contrast studies are neither sensitive nor specific for diagnosing GERD. Therefore, this test is not recommended for the diagnosis of gastroesophageal reflux disease. With regards to the prescription of PPIs in irritable infants, multiple studies have shown that these drugs are ineffective and may cause a wide range of adverse reactions. And of course, all guidelines recommend not to use ACE2 receptor antagonists or PPIs for the treatment of regurgitation and crying in healthy infants. At 4 months of age, symptoms were still not improving. His weight gain also remained poor. Mom said that although she wanted to continue breastfeeding, she was stressed and just couldn't do it anymore. So parents decided to seek a second opinion. After consultation with the second pediatrician, other tests were conducted, including skin prick testing and serum specific IgE for milk, soya, egg, and wheat, all negative. You can see that hemoglobin concentration and ferritin levels were found to be on the low side. And as you can see here, a variety of investigations were performed. It's also important to have in mind that IgE sensitization tests, such as skin prick testing and serum-specific IgE, must be interpreted in the context of the clinical history and not in isolation. These tests detect sensitization and not necessarily clinical allergy. So they may be used to help diagnosing IgE-mediated clinical allergy, which is not the case of our patient. Here's the second question that I pose. What diagnosis do you suspect? Is it infant colic associated with infant regurgitation? Is it cow's milk allergy presenting with symptoms of GERD? Is it infant regurgitation and lactose intolerance? Or is it gastroesophageal reflux disease? I think, again, you can vote on this and then we will come back to our case.
I think you have a couple of seconds to vote. We have then a 3-month-old baby, now 4 months, who refuses bottle, is vomiting after most feeds, he's irritable, doesn't sleep, and is not gaining weight since the age of 2 months. He was submitted to a variety of investigations and pharmacological treatments with no improvement. So we have our responses here. Thank you. We can see that most of you would consider the diagnosis of cow's milk allergy presenting with GERD symptoms, but some of you would say that this baby has infant colic associated with regurgitation or gastroesophageal reflux disease. Although it's not impossible, it's uncommon for a baby with functional gastrointestinal disorder to present with growth faltering. But of course, in infants already on complementary feeding, this may occur to excessively restrictive diets or feeding difficulties. And so returning to our initial poll question, blood in the stool is not, does not happen in functional gastrointestinal disorders. Lactose deficiency, congenital lactase deficiency is an extremely rare condition. And now we have to think about the next step to differentiate GERD from cow's milk allergy. This is the case where these recommendations for recent guidelines for reflux are appropriate. A trial of a hypoallergenic formula should be considered. We have to have the diagnosis of cow's milk allergy in the back of our minds. Parents then decided to seek a third opinion. The baby was commenced on an amino acid-based formula, and this decision was made based on the baby's faltering growth and to avoid the risk of having yet another failure with an extensively hydrolyzed formula. It is important to provide reassurance and educate parents about the whole process. What I tend to do is to tell parents that we don't need to prescribe any medication, and it may take days or weeks for improvement. Within a week, there was improvement of symptoms and appetite increased. With this progress, we scheduled a follow-up evaluation to decide the appropriate moment for an oral challenge, possibly in 2 to 4 weeks. I think the messages we get from this case is that the diagnosis of cow's milk allergy is missed quite frequently and needs to be considered in the differential diagnosis of gastrointestinal manifestations in infants. We are still seeing a growing number of patients presenting very late. We need, of course, to remember that for us working the front line, it's not a one-size-fits-all solution. Early diagnosis and early intervention will prevent or reduce maternal stress and anxiety, avoid unnecessary laboratory tests and pharmacological treatment, and reduce as well the risk of faltering growth. The number of babies that are prescribed PPIs is huge, and there is no evidence to support the use of medication for infants with regurgitation and irritability. Of course, we have to improve the understanding of guidelines and use our clinical skills to make sure we avoid under and over diagnosis. And before I finish, I will leave you with this quote from this American orthopedic surgeon that says, the patients will never care how much you know until they know how much you care. With this, I will hand over to Roseanne for the second case, and I thank you all very much for your time and attention.
Thank you, Mario. I mean, this case just demonstrates how complicated things can be. And I think one point I wanted to take on was, you mentioned the use of an amino acid formula within that child. Of course, that was absolutely appropriate because you had faltering growth in that child and you get better longitudinal growth. But yes, the message of listening is one that we'll be repeating several times. So if we move to the next slide of my case, this is this time of a baby girl that was referred with abdominal discomfort leading to poor sleep. And I think many of you have heard that the parents were saying that this baby was actually sleeping on one of them, as otherwise she would not sleep. She does not vomit at all, but they do report when after a feed, she would pull her legs up and back arches with discomfort. She produces only 1 stool per week, and parents report that she's in discomfort while stooling. Now, on that point, of course, there's huge variations in young infant stooling pattern. But I always say that a child that has huge amount of discomfort, that's what I normally take as very serious when a child is not, a child is actually in distress. Feeds are short, and she needs a lot of distraction for her to consume a significant amount of volume. So if we move on to the clinical history, child was born at full term, had some respiratory distress, blood sugar levels were low at just after birth, and had also hypothermia. There was, rightly so, some concern about neonatal sepsis, and this baby received 5 days of IV antibiotics. The sepsis screen came back negative, but the baby still had 5 days of antibiotics. Birth weight was 3.3 kilograms, and for those of you working with Z scores, that is just above the 25th centile, so just at minus 0.45 about for Z scores for weight for age. She lost 4% of weight, but regained that without any difficulties, and then was discharged home. The parents report that soon after discharge, she became uncomfortable. She started crying for between 40 minutes and 1 hour. And that makes now the background you had from Mario very much alive on the definitions of crying time. They were told that this was quite normal, but this worsened, and by 12 days they took her to a pediatrician who diagnosed a posterior tongue tie. Frenectomy occurred at 14 days. I think for many of you, certainly for me, I see this often happening, that this is being diagnosed and blamed for a lot of conditions, and it's you have a frenectomy, but that does not change necessarily the feeding pattern. Neither parents are atopic. Baby had no sign of eczema. So let's move to the next slide. The feeding history is quite impressive, I think is, for me, made a huge impression, because I think it's so common to see that. So this baby after birth had a combination of breast milk and standard infant formula. As she became more uncomfortable, which you can understand, mom could not sustain breastfeeding and switched to an organic infant formula. Certainly for us, in the UK, if you go to Google, there's a lot of Facebook groups and they recommend going for organic formula. But this made absolutely no difference, and she continued to scream for 2 to 3 hours per day in discomfort. And a pediatrician suggested a change to a lactose-free formula, but this also made no change. So you have to remember now, we're now down to our 4th change. So we've had breast milk, standard infant formula, organic formula, and we've now had a lactose-free formula. They were then advised to switch over to comfort formula. Most comfort formulas, they changed a little bit, but they are primarily partially hydrolyzed protein, low in lactose, and they thickened as well. If we move just back to the feeding history, and then because that didn't work, she also developed painful flatus. They went on to Google and they thought that they'll try goat's milk formula, as on one website it suggested that this was suitable for cow's milk allergy. Now, for all of you that are attending, of course you know goat's milk formula is not suitable for a cow's milk allergy, because the protein homology is around 95%. I always say if goat's milk formula is tolerated, we are not dealing with a cow's milk allergy. So this was not making any difference. So this is feed change 6. They did say there was more settling, but the constipation continued and she was really struggling. And then they were recommended 50 milliliters of fruit juice to help with the constipation. So you can see lots of things happen. So if you move to the next slide, and now we're going to look at growth, and you can see growing beautiful. So just the 50th centile is 0 in terms of your Z score. If you go slightly below, that's where we are at just around -4.5. So you can see head circumference length, no concern about growth. So if we move on then, we are going to do the first question. And this is going to be exactly the same as you had with Mario before. What diagnosis do you suspect? Do you think this is infantile colic constipation? So it falls within your functional gastrointestinal disorder. It's non-IgE mediated cow's milk allergy. It's a problem with parenting. And for those of you who are really unsure, I've given you a way out. I've given you a way to stand on the fence. You can say, well, this is either functional gastrointestinal disorder or cow's milk allergy. And, you know, I'm thinking about that graph that Mario showed with the two circles interlapping, where you've got functional gastrointestinal disorder and you've got cow's milk allergy, but you've got some overlap between the two. So you've got a couple more seconds. And actually very interesting split, so almost a 30-30. So we've got almost 30% saying I'm sitting on the fence, could be either. And then you've got 33% saying I think this is functional gastrointestinal disorder. Then we've got 30% saying I think this is non-IgE mediated allergy. And then a small percentage say this is problem with parenting. So let's move on, because I think my next slide might help us thinking about where we're going. So now we're going to go exactly the same question. Would you be doing any investigations in this child? Would you do specific IgEs for milk proteins? Would you do an upper gastrointestinal endoscopy? Would you do an ultrasound for reflux? And you now should know the answer to that because you've had the background to that. Or would you do absolutely nothing? And you would actually just focus on your clinical history that I've just shared with you. So you've got a couple more seconds and then we'll have the answer, and I see it's coming through. The vast majority of you have said none. Mario, would you agree with doing absolutely no investigation, or would you actually in this case do any investigations?
I couldn't agree more, and that's what we've been saying during all the seminar or all the webinar. This is very
because
nice.
My experience, in fact, is that a lot of time the ongoing investigations can often increase the anxiety and just extends the time that the parents are struggling to figure out if they've got what is the diagnosis. Right, so let's go to the next slide. So if we are thinking about functional gastrointestinal disorder, so Mario, if you can move to the next slide for me. So you've seen already this kind of graph. I want to first remind you, because I think Maria made a very important point, is we have guidelines, but we have our clinical judgment at the time when you see the patient. So when I saw this patient, they've had 5 different feed changes. So I think that plays a role. So just let's go through the kind of role of managing infantile colic. So you've got the red flag signs. This child has got no red flag signs. But is there suspicion of allergy? So that might be a trajectory that you go down. And if you go down to the trajectory, you need to then change the feed again. You may actually go and say, actually, I might move towards more, this is functional gastrointestinal disorder, and I might more go for probiotics and partial hydrolysis. So let's go through that and what the decision would be that you make. So let's go to the next question, that you need to choose your treatment option. So your treatment option is you can either go here for an amino acid formula, you can stay in goat's milk formula and say, well, the argument here is goat's milk formula is of course not dairy free because it still has got 95% protein homology. You think actually it's something totally different. You go for an extensively hydrolyzed formula. So you take the track down, it's a cow's milk allergy. You stay on the same formula, which is in fact at the moment the goat's milk formula, but you add probiotics, and you've heard a little bit more from Mario about that, or you change nothing. Absolutely nothing. So what would you do in this case? You've got a couple more seconds to have a think about this question, because it is quite complicated to think in a case like that. But I think all of you have seen cases like that to decide practically at that moment what you're going to do. So I see the answers are coming forward. So it's an interesting split. So we've got the vast majority would go extensively hydrolyzed formula, so the track down to say I'm first going to see if there's an allergy, or you'd stay on the same formula and add a probiotic, and a small number said amino acid formula. Now for me there were no warning signs here, so for me I would only go if I'm thinking about cow's milk allergy to amino acid formula if there was severe filtering growth, which in this case is not the case. So if you're going down the track of extensively hydrolyzed formula, it needs to be extensively hydrolyzed. So that's what we did, because I felt for this mother, we need to get an answer. Is this cow's milk allergy or not? And this would give you that. So we tried for 4 weeks on an extensively hydrolyzed formula with prebiotics. And then after 4 weeks, symptoms improved. But we then decided, because that is absolutely critical, because if you look at the weeks that Mario highlighted in terms of functional gastrointestinal disorder, we need to make sure, is this really cow's milk allergy, or is that actually the child's natural growing out of some of the symptoms? So we challenged, for us, our challenge is over 1 week where we build up, so it gives them enough time, and no reaction occurred and no worsening of symptoms. So we actually proved in this child it was never a cow's milk allergy. But we worked on the parental anxiety and the psychological input. This feeds back to what Mario said as well, is it's really important if you think about the journey that these parents had. It was a journey where lots of healthcare professionals were right, where 5 feed changes had occurred, and they were actually convinced there was a medical cause. So we move on to kind of wrap this session up between us. The practice points really are to consider the impact of the feed change itself, to think about the symptoms, what is perceived and what is real. And if it's perceived, we are not going to say, well, this is just in your head. You're going to say, I'm listening to you. Let's see what we can do. Because just by listening, you can really make a difference. You need to think about the psychological well-being. If I just take these parents as an example, these parents have not slept. This child is sleeping on top of them. So that part of it needs to be taken into account as well. You need to listen, which we've reinforced before. It's important that the choice you make, you're not just making a choice, you're using a feed to bring you closer to a diagnosis. And that's the decision that I made in this case. It could have been that you said, okay, I'm doing the other route, doing probiotics, and then come through. It's not that that's wrong. So you often need to make the decision with what you have in front of you. So, and a last message, which both me and Mario made, is really the diagnostic factor, which you need to challenge and bring this back in. In this case, if you had left them, you would have put this child on a milk-free diet, you would have had solids that were milk-free, and that would have not been fair. Okay, so let's wrap it up and go to our concluding remarks, so that I see a lot of questions have come through. So let's move to the last conclusion for both of us, that there's a high prevalence of functional gastrointestinal disorder, and you've seen that in the numbers that Maria presented. The etiology often is unclear, but the differential diagnosis between functional gastrointestinal disorder and cow's milk allergy is challenging. And yes, you often have this overlap. And so if you do make dietary changes, you need to challenge. Testing and pharmacological treatment should be avoided in the absence of warning signs. And that we've gone through PPI and we've gone through the testing as well. That's really important message. And yes, for those of you who've wondered, there is a link not only with the overlap with diagnosis, but children that have had the cow's milk allergy in early infancy. The new data is pointing towards that there's an allergic march, and a small percentage does have functional gastrointestinal disorder in later life. So thank you very much. And I think we are moving now to questions.
Thank you, Roseanne and Mario. I thought it was incredibly interesting, and so many clinical pearls that you take away from your presentation. So thank you for sharing your experience. And I think the compassion and listening and just acknowledging what the parents are going through is incredibly important. So we have received a number of excellent questions, and I think I'll start with the questions for Professor Mario Vieira. Mario, what are the indications? You mentioned that only 5% of the functional gastrointestinal disorders have some organic cause, but there's one question about the indication to refer a constipated infant to a surgeon. When would you consider that?
Thank you, Anna. This is a wonderful question, because we have to be aware of alarm signs. most of infants who are exclusively breastfed, they do not have constipation. So if you have an infant with constipation, first you have to define, is it constipation, is it dyschezia? If he's breastfed and has no alarm signs, only education and reassurance is enough. But if you have alarm signs, you have to be very careful with the clinical history and physical examination. For instance, if you have delayed passage of meconium, this may suggest Hirschsprung's disease. If you have marked abdominal distension, growth faltering, and then you put everything together, and then in our setting, we tend to investigate first. We proceed with imaging studies, manometry, or rectal biopsy to diagnose Hirschsprung's disease, and then we refer and we discuss with the surgical team.
Thank you. I mean, this is great. Another question for you, Mario, that sort of ties together, is what's the role of testing for fecal occult blood, for using hemoccult and evaluating infants or cow's milk protein allergy? And then another question that sort of ties into it is this: isn't it just normal? Like, don't babies bleed, from their rectum because they're immature and they're developing their gut? I think those are very interesting questions.
Yes, absolutely, yeah, and very practical as well. Thank you for this question. Actually, I don't proceed with occult blood in stools. I think this is a test with a high sensitivity and extremely low specificity. So anything can show occult blood in the stool. So this test is not useful at all. And,
so you look for blood, right? Like, you want to see blood, not testing for blood. You want to see it.
Yes, that's right. You have to see actual blood on the stools. Regarding blood in the stools, it's interesting because blood in stool is not normal. It's not normal and causes great distress to parents. So it's interesting because sometimes in our setting, we see that some colleagues, they work under pressure or budget pressures, and some important symptoms like blood in stools sometimes are neglected. And then we get the delayed diagnosis because, well, you cannot tell the mother, okay, blood in stool is normal and it's just because of immaturity. So this is not true.
Thank you. This is great.
If I might just also say, I think there's something that's really good and might be very useful for our listeners is we are all a part of the task force that have written the article on non-IgE mediated allergy in breastfed. And this topic on blood and stools is discussed in quite detail, and we give very practical guidelines on that. So if you look at non-IgE mediated in breastfed children, you'll find some very practical tips.
Good point, Roseanne. So there are questions for you. I really enjoyed and I really appreciate you emphasizing and both you and and Mario emphasizing that this sort of diagnostic trial of elimination diet has to be followed by the re-challenge. So the question is, how do you re-challenge? You have achieved control of the symptoms and now you have to reintroduce cow's milk, formula or cow's milk protein in a different form. How do you do it? Do you do it just, just go full force, or you just go, gradually?
So if I'm going to start, because I think it's good to have all of the different views. I think there are three situations here. The first one is convincing the parents that a re-challenge needs to occur. And I think for all of you that it might be sometimes, we like to re-challenge within 4 weeks, but I'm also going to be honest, there are some parents that beg us and say, can we just wait another 3 or 4 weeks because it's the first time we're sleeping? And I think this is a very important process. I talk about the re-challenge when we do the elimination, not when they're better. So I think that's the first thing. And I said there were another two out of there. Then we have the breastfed versus the formula fed. So for the breastfed, I don't do any ladders or anything. I just tell the mother to go for it. So if they had cheese and yogurt, to go for it, because from the little evidence that we've got, whether the mother has yogurt or baked milk or, the beta-lactoglobulin doesn't change. In my bottle-fed children, my preference is to really go for it. We do give it a week because I do find children, it can take some time. I do have parents that ask me, can I do it in a milk ladder? Now, for diagnostic process, we don't use the milk ladder approach. But I also want to be here really practical. I prefer to challenge. If that means that that's the only way the parents are prepared to do it, then I will do it that way, so that I can prove that we are not actually seeing a false positive.
I totally agree, right? Like you have to sort of work, and you have emphasized, both of you have emphasized that, you know, you look at the patient, you look at the parents, and you work with them, and you have to consider their experiences. There was another question for you, Roseanne, I think, because it ties very nicely to your case presentation where you talk about goat's milk, you know, that it's not really a great substitute, you know, for an infant with cow's milk allergy. But what about camel milk? And, you know, would you consider, you know, when it's available, obviously it's not like readily available to everybody, but when it is available.
No, but Anja, it's a very, very topical subject, because if you look at now on PubMed, in total there are about 12 publications. Many of them are opinion papers. So first of all, from an in vitro study, the protein homology, there is protein homology, and depending on the protein, 62 to 65%. So it is much less. Goat's milk, you know, we're looking at 95%. There are, I think there are two particularly interesting studies, one which is a crossover study, but I want to say that study is 2018 and actually starts only from 1 year of age, so not the infants. So they had children that went swapped over, so you had a nice washout period, and they had double-blind challenges of cow's milk. And actually in those, all of them tolerated the camel milk. But for me, it's actually the population I'm really interested are the babies. And there are now some studies coming through. The one study in particular that I'm referring to has got 15 babies, and what they found is actually that it's about 40% that tolerated the goat's milk formula. So in some of the countries in the Middle East, you can get goat's milk formula, but this was IgE and they were skin prick tested. So they actually did not introduce it before skin prick testing. For me, I work in a country where you don't get it. I think I'll need a little bit more convincing to use it routinely. But I think if you've got a formula and you can do skin prick testing, and there's some data, I think I would challenge them, to be honest. I would challenge them to it. As far as I know, there's no data on non-IgE mediated cow's milk allergies. So I think it's a moving area, but I think it's interesting.
Yeah, well, this was a wonderful discussion, and we have so many more questions, which we don't have the time to address right now, but we are going to address all of your questions, we promise, and we're going to send it to you, you know, within a couple of weeks once we have the opportunity to record those, you know, our discussion on those questions, because questions are really fascinating and really reflecting, you know, big interest. So thank you again for such a wonderful presentation that was, you know, really incredibly practical. And if, you know, with my experience, I can really appreciate, you know, the level of, you know, expertise and the insight that you're providing. So this was fabulous. Thank you.
Thank you for the invitation, and thank you for those of you who stayed on for this evening talk.
Thanks everyone for attending. Thank you. Bye. Take care.
Have a good day. Bye-bye.
Bye.